Alrighty. Thank you, Nelson. Thank you, colleagues, for joining this call. And great appreciation to the panelists also for joining this conversation at this hour of the day. It is an important conversation for us now in the HIV space, and we are glad that we have you all on board. So Nelson, if you'll allow me, I will do a very short presentation just to give a background of this conversation. Then we'll go straight into getting insights from the different panelists that we have on board today. All right, so I think the conversation around integration is not new to those of us that are in the HIV space, but we thought because we are addressing colleagues from different spaces, that it would be good for us to set a bit of background and give context to this discussion before we go into it. So there are several definitions of integration that have been put out, and for those that are relevant to our conversation today, we'll look at them a bit. So one of them, of course, is from the WHO, and they describe integrated health services as being health services that are managed and delivered so that the people that need them or the recipients of care receive a continuum of services. And by a continuum of services, we're looking at services ranging across from promotional services to prevention, to diagnosis, care and treatment, and even rehabilitative services, and that these services be coordinated across different levels of care and different sites, both within and beyond the health sector. And most importantly, according to the needs of the people who we are giving the services to. So this is one of the definitions that have been put across for integration. And in literature, we have a further breakdown of this definition. So there are several levels at which we can look at integration. There is system level considerations for integration. There is organizational level considerations for integration. And then there's the actual service delivery or the service level of integrated services. So of course, when we're looking at system level considerations for integration, we are looking at how we are aligning ourselves to the rules and policies within a system. And in our case here, our system, of course, is the larger Ministry of Health and the priorities that the Ministry of Health has put forth when it comes to issues around health services. We know that our current government has prioritized the digitization agenda, for example, universal health coverage for our recipients of care within the health system. The current government has also prioritized primary health care, including community health strategy. And then, of course, we also have to look at the different health system building blocks and how we are aligning as a program to the investments and the different priorities within these different spaces, of course, including health products and technologies, human resources for health, and service delivery, among others. When we're looking at organizational integration, we want to look at how well are we working with the different organizations within the space that we are in, that is the space of offering services that are either HIV, STI, and hepatitis. So when we're looking at organizational integration, it can be as big as governments as organizations. So how are governments collaborating when it comes to planning for service delivery? And also how are our programs within the Ministry of Health working together, the different departments, the different programs, and the different sections within the Department of Health. So of course, we are looking at the different program areas like reproductive maternal child health. We're looking at the TB program, TB leprosy. We're also looking at non-communicable diseases as organizations within the Ministry of Health, through which NASCOP, of course, should be able to collaborate with to ensure that we continue offering people-centered services. Then lastly, there is the service level considerations for integration. So the actual clinical integration, where we need to be very cognizant and very keen to ensure that we offer comprehensive services that are people-centered or person-centered. And by people-centered, of course, we are looking at the different constituents of recipients of care that we serve in their uniqueness. So, of course, we are looking at children who are some of the constituents of the recipients of care that we serve. We are looking at adults. We are looking at populations that are at high risk of being infected with HIV and STIs. That is our key populations and our vulnerable populations, and all the populations that we serve. So we need to make sure that the services that we put across are comprehensive and sensitive to the populations that we serve. Therefore, at NASCOP, basically, when we look at all these three angles for considering, or rather for consideration in the integration agenda, we are looking to be able to continue offering people-centered services, which we have done over the past few decades, and ensure that the services that we are offering are being offered through a system that is aligned and anchored within the Ministry of Health's policies and priorities, and of course also within the larger government of Kenya's policies and priorities, and through collaborative efforts between the relevant organizations. So this is our working definition for integration of HIV, STI, and hepatitis services in the broader health system. And this is going to form the context for our conversations today. Allow me at this juncture to stop sharing and put down my screen so that I can introduce the panelists that we have in the house today. We are privileged to have been joined by all the panelists that we hoped would have been able to join us, or at least representation of them all. We have Nelson Otoma, who is the Executive Director of NEFAC, the Network of People Living with HIV. We have Dr. James, who is the County Director of Health for Murang'a County. Karibu sana daktari. Thank you for sparing time to join us. We have Eunice Kinywa, who has been the HIV program coordinator for Kisumu County, and is going to share with us some key insights on what has been going on in Kisumu around the integration agenda. Karibu sana, Eunice. We also have on board Dr. Lely, the County Director of Health for Kilifi County, representing Waziri Mheshimiwa Peter Mwarogo, the Minister for Health for Kilifi County. Karibu sana daktari. And last, we have Dr. Andrew Mulwa, who is the head of programs for the HIV program, that is the National AIDS and STI Control Program within the Ministry of Health. So, karibu sana, Dr. Mulwa. I don't hear responses. I want to assume you can hear me clearly. And
thank you, Daktari.
Yes, we can. Thank you.
Okay, fantastic. So thank you so much for joining us today and agreeing to contribute to this conversation, especially at such a time when we have had, I would say, some shocks as a result of some of the US government directives that were given earlier in the year when or after the new president came into office. So I'll go straight to the questions. And I would like to start with you, Casco, Eunice. So I think when we got the directive as a country, from the US government. Kisumu County might have been the first county that sent out some communication to, or rather a memo to healthcare workers within the Department of Health. And I think that was necessitated by what was happening around service delivery, not only in Kisumu County, but generally across the country. And there has been a lot of ongoing conversations around integration over the past few years, and it was almost becoming a buzzword within the HIV space. You have implemented integration already to some extent, and as the technical lead for the program, what does integration mean to you? And what does integration mean for Kisumu County? Maybe you can share with us some insights on that. Karibu, Eunice.
Thank you very much, Dr. Kapanga, and for giving me this chance to actually be able to provide some few insights based on the experience that we have for Kisumu. And just to be able to mention that we had begun integration even before this top work order came in. And we had no clear definition. We actually had we had no clear model that was going to be implemented, though we had guidance for the different service delivery levels. And this is also in line with our transition agenda that we actually have a transition roadmap, because we know very well that we are on a journey to self-reliance. And as a county, we had actually begun these discussions of transition. So this was part of our agenda. And just to be able to speak to really the what, as a program officer, what integration would really mean to me, and looking at integrating HIV, STI, and hepatitis services, this really represents a holistic approach to health, to public health, and it actually facilitates comprehensive care. And really, when you look at comprehensive care, because even as you talk about HIV service delivery, there's a lot of comorbidities, there's a lot of issues of new diagnosis of non-communicable diseases. So really that comprehensive care becomes a key issue to us. Again, this really looks at improving resource efficiency, and more so when we're looking at human resource that we are always constrained with. It also improves the patient engagement, and even just looking back to some times before we even had integration of HIV and TB, and when we were using nevirapine, and we know very well with the issues of anti-TB. So there were instances where you'd find a client getting TB services in another facility and getting ART services in another facility, and they would never disclose that they were on ART. So there was a lot of issues of drug interactions at that particular moment. And this is what integrated services would really come in to address. It's a crucial strategy in reducing stigma, improving health outcomes, and also ensuring that our clients receive a coordinated and more effective management. And just to speak a bit about comprehensive care, especially within a single healthcare setting, it actually makes the patient more likely to receive timely diagnosis, treatment, especially for the comorbidities. And we know, even according to WHO, there is actually a lot that we are told that integrated service delivery models has been observed to reduce morbidity and mortality, about 30% reduction of the same. So that's what I would be able to put into that.
Thank you. Thank you very much, Eunice. I think you have touched on a lot of areas with regards to how Kisumu has interpreted and experienced integrated service delivery. And maybe just to mention, for those of us that are not aware, Kisumu County was one of the counties that put out a memo instructing healthcare workers to integrate HIV services into primary healthcare, especially at our level 2 and 3 facilities. So as they speak to us, they are really talking about what is happening within their county and what is really happening on the ground. Thank you so much, Eunice, for those insights. I think I will pick on one of the areas that you have highlighted when it comes to some of the benefits that you have seen around offering integrated services in the county. And one of them that you mentioned was resource efficiency. And if I heard you correctly, you said that when we're looking at resource efficiency, it especially touches on issues around human resources. I would like to switch to a director for Murang'a County, our county director for health, Dr. James. Looking at issues around human resources for health, when it comes to integrating services into the broader health system, from your experience and extensive work in Murang'a County, how can we manage and maintain health care workers to be able to deliver not only integrated, but more specifically and importantly, quality services for our recipients of care? So, Karibu, please share with us some of the insights based on what you have been doing in Murang'a County. Dr. James.
So thank you very much, Dr. Kapanga and the other panelists and those in attendance. I'm grateful to be in this panel. Dr. Mboro James is my name from Murang'a County. So basically for me and the county, that's a key area in terms of continuity of service delivery. So the experience that probably I would wish to share is that just like my predecessor has pointed out, we had started this transition process earlier on. And I think where HLH is concerned, one of the key entry points was to map out key stakeholders who would be involved in terms of integration and to ensure continuity of quality service without losing the accrued gains. So I think we quickly set up a roadmap, and in that roadmap, the so-called the county transition plan, we identified the key stakeholders who had a direct impact, or rather a connection as far as HLH is concerned. And these key among them, of course, in the program, because we have two approaches in this program. We have a direct funding through the G2G mechanism and a sub-award by a prime recipient. And therefore, we had a staffing matrix of around 180 different cadres. And therefore, we identified who these cadres were, their capacities in terms of training and experience in service delivery. And of course, the other major key stakeholder in that matrix was the county assembly, because of course of budgetary issues, the county executive itself, and the county public service board. So those were key stakeholders in helping us address the HLH component. But where actual service delivery is concerned, our key actors, now led by the county health management team, the sub-county health management teams, the focal persons, especially those coordinating HIV, TB, malaria, and those are the other now additional stakeholders who came on board very quickly to assist us in mapping and identifying mechanisms to ensure continuity. So basically, it has been it's work in progress, because immediately we received the stoppage to work order, we met with these stakeholders together with the prime the prime recipient and of course other actors in that area to map out and strategize on the way forward. And I think one of the key areas was to identify our key strengths, and probably I'll be sharing later in terms of what we were able now to identify in terms of the key service areas. That is, for example, the laboratory service, where we have a unique sample transport. And that is one area where we identified that we had our own county-owned staff who were involved in sample transport. It's especially as far as the lab service was concerned. The other area is in the area of pharmacy and PMTCT, and of course, the actual key service delivery by the clinicians. So basically, that has been our trajectory. We have ups and downs, we have hits and misses, but our key focus is service delivery continuity without losing the gain. So probably later on, I'll be elaborating on each of those in terms of what our experience has been. Thank you.
Thank you very much, Director. Before you go off, maybe I can just ask a brief follow-up question. I know you have mentioned about the county transition plan for the program.
Yes.
Has there been any plan around absorbing the partner-supported staff or the staff that were working under the G2G mechanism into the county government payroll? Is there any work around that?
Yeah, thank you very much. That's a very good follow-up question. And yes, and that's why in several meetings, we have brought on board the County Public Service Board for them, of course, to take ownership in terms of staff transition. So that is a process that we are undertaking with the board so that they understand the staffing portfolio for them to see what would be the mechanism for onboarding them. Of course, they have identified one of the key challenging area will be those staff, for example, without a scheme of service, the lay cadres, and therefore that is a key area that we are also focusing on. The other aspect we did on that is to bring in the County Public Service Board. The County Assembly, because of course onboarding these staff has a budgetary component. So we have a subcommittee which has been looking at the HLH budgetary implication so that the County Public Service Board and the County Assembly would of course now be involved in, of course, onboarding that budget for the board to be able to onboard these staff. So I would say this is a work in progress. Those two entities are fully appraised and they are working on it, but we have not successfully onboarded the staff this far. Thank you.
All right. Thank you very much, Director. I think we are picking a lot of lessons in terms of some of the things that you had already done prior to this directive or the instructions that came from the US government that are helping us even be able to progress when we're talking about continuity of services. So I think especially on the issue of stakeholders and who really must be on the table when we are talking about or when we are discussing about continuity of services, that is key for us to consider in this conversation. So I'd like to move on to Dr. Lely. Dr. Lely, you're here, you're representing the Minister for Health for Kilifi County, Karibu Sana. I'm curious to know for Kilifi County, we have to remain cognizant of the fact that we are trying to align and anchor the HIV program into broader health systems. So in light of this, or in line with this, what is your ministry's vision and strategy for integrating HIV, STI, and hepatitis services into mainstream healthcare? So, and how does this vision specifically align with particular health priorities for Kilifi County? Dr. Lely?
Thank you so much, Ruth. I'm here on behalf of the CEC. He conveys his deepest apologies, but he had some travel logistics issues that's why he wasn't able to be here. So just jumping straight to the question. The integration of the HIV, STI, and the hepatitis services really do fit within our county's mission. That is to provide quality health services that are available, affordable, accessible, sustainable, and equitable to the population of Kilifi County and beyond. So like what Dr. Buru said, we had started the discussion of integration quite a while back, before even the notice that was given by the US government. And we had started by mapping out the key areas that we could start with. And we had had discussion in terms of integrating level 2s and level 3s. And we are glad we had this conversation with our partners, the USAID implementing partners at that time, who are on board with the discussion together with the USAID mission itself. And we also put up a plan for the level 4s. And I'm glad one of our level 4s, that is the key level 4, that is the Kilifi Referral Hospital, was one of the pilot sites that we have started integrating. And how did we start? We have started integrating in terms of the chronic care treatment. We're integrating with the HIV, STI, and hepatitis comprehensive care clinics. So this allowed us to, first of all, rationalize resources. Resources being in terms of infrastructure, in terms of HPTs, that is health products, as importantly, human resources, because this allowed our consultants, that is the physicians, the clinicians, and the medical officers, to play a part in terms of providing accessible services throughout to the entire population that was seeking comprehensive care services, chronic care services. So this allowed us, even when the circular came out, we were already in transition for the level 4, that is the main level 4. And these lessons which already we had gained allowed us to now replicate this in our other level 4s. But to level 2s and 3s, we had also started that journey. So I'm glad it was not really a shock to our system, but rather found us already adapting. Already with this, we made it so that we could not lose the gains that we had made already as over the years in terms of the delivery of services, because our aim is to be patient-centered while maintaining quality of these services. And also the benefits already we had, even from the research already we had seen, it allowed improved access, reduced stigmatization, also patient outcome, and importantly, like I said, cost savings, because the discussion of integration had started way before the transition of the current US government. So for us, it had been a lesson that we had been implementing, and currently we are started learning as we are going. But importantly, it has allowed us to really put a clear picture in terms of how do we re-strategize the system of care, which I'm glad we have been doing, and we have managed to see. Importantly, for us, in terms of ensuring sustainable financing, not only for the HIV and STI services, which has allowed us to take advantage of the existing legislation that the country has been moving to. And what am I saying? I'm talking about the FIF. It has allowed our facilities to ring-fence financing, and Kilifi has been one of the counties that have been implementing facility improvement financing before 2022. So we have been doing it since 2019, and the experiences as well have been in terms of raising our own source revenue, which has helped in terms of improvement of services, being patient-centered. Importantly as well, our main goal has also been strategizing the use of the CHP program, because our county also passed a Community Health Services Bill we started developing it in 2021. So it has been something that has been also taking an approach in terms of linking the services to our community. And also, importantly, we are also looking at how do we work with the peer educators, who are a very large youth population, and trying to integrate them into the community health service program. Yeah.
All right. Thank you very much, Director. I think you have touched on a lot of very important points. I would like to pick on one, the issue around working with the community health promoters, that is those ones that are within the community health strategy. And I will shift to Nelson. I think one of the challenges we have had when trying to engage the community health promoters in issues around, especially HIV, has been about or around stigma and discrimination. And we know that stigma and discrimination has been a barrier to access and even to adherence to treatment in some parts of our country, and also in particular pockets even within our facilities. So, Nelson, I would be curious to know what you think about stigma and discrimination. Do you foresee an interplay between stigma and integration of services? I think when Dr. James spoke, he also talked about one of the things that they have seen as a county. Dr. James also and Eunice, they mentioned that some of the things that they are seeing now is that there is reduced stigma. But from where you sit, what do you think about this? What are your insights on issues around stigma and discrimination and the interplay with integration of services? Nelson?
Thank you very much, Dr. And thanks again for having me. And I want to say that you had a good selection for this webinar. You have some of the best speakers, the best people to speak on integration, as we have already listened. I will be getting to your question on stigma and discrimination, but before that, allow me just to have a few reflections. And to say that integration, I agree with you and I agree with the previous speakers that it is not new. And we all remember the Ministry of Health leadership convening in Mombasa to talk about the integration summit, which actually demonstrated the need. And I think when we left Mombasa, it was not a matter of if, it was a matter of when. And of course, there are also recipients of care who are in Mombasa and who are speaking the same language with service providers and policymakers. And it made a lot of sense, including even to people living with HIV who are aging because of the issue of integration with the NCDs. So it is not something that we are hearing for the first time, and it is not something that the Ministry of Health is compelling people or pushing people to get into. However, with the unveiling of a stop work order from the US government, I think that's PEPFAR USAID and how it came, we have seen a very rapid and dramatic way of trying to integrate services. And I want to say that in Mombasa, we had a report. It was a summit, and then a report came out. We had hoped that some document from Muranga, what we have seen, I hope my voice is clear. What we have seen is that we are trying to undergo or undertake integration of HIV care into health services using memos. At least it would have been better if we had guidelines to inform this integration. So even though we have guidelines from Muranga and Kilifi, which probably recipients of care did not engage in developing, but at least that's a step going forward. And we know the pillar in Muranga is the human resource, as has been explained. But for all other counties, I don't think you can give a memo to healthcare workers and expect that recipients of care will also understand what you are talking about in terms of integration. But again, going back to the Mombasa summit, the question from one of the veterans and one of the people who have been in this space for long, a scientist and also a programmer, Professor Kimaiyo, was, are you integrating HIV into other health services or the other health services are coming into HIV? That question has never been answered. The key reason why persons living with HIV supported integration is also not addressed. It is ignored because the issue was non-communicable diseases, particularly hypertension and diabetes, and of which you know where we are with the Social Health Authority and Social Health Insurance Fund. And in the last 2 weeks, when this integration has been intensified, we have not seen any attempt to address this in the recipients of care. And generally, then we think that we need to approach this with abundance of caution, in as much as we know that there has been continuity of services. What we have seen from the Ministry of Health and also county governments is an assurance that ART is available and in sufficient quantities. And of course, nobody mentions, like Buranga is very clear, but nobody mentions who is dispensing this care with the massive layout, with the lower level cadre of staff. So that is just that. But I want to say that when it comes to stigma and discrimination, actually this has been the challenge. And the challenge has been both in science and also in experience. In science, In NEFAC, we roll out what we call PLHIV Stigma Index, and it is a study that is even supported by NASCOP, NSDCC, and other partners. And when we carried out one in 2021, and again repeat in 2024, more than half, 62%, of people said they delayed HIV testing in as much as they were being advised. Because if they turn out positive, others may know. And if others know, then that would also be disastrous to them. And then a good number, 47%, almost half, also said that they were tested, they knew they were HIV positive, and they know the policy of test and start, and they delayed treatment simply because they were not in a proper frame of mind if anybody finds out they are HIV positive. And also, there are also people who have interrupted treatment, and we've been asked by the Ministry of Health to try to find a few of them and find out why are people interrupting treatment. Because if you interrupt treatment, you will present with opportunistic infections. Right now, we are talking about advanced HIV disease. The real cause of advanced HIV disease are people who delay or people who interrupt treatment. And they delay and interrupt treatment because if they go to a facility, somebody else, whether a clinician or other healthcare worker or a community member or their relatives or friends or workplace colleague will find out that they are HIV positive. And of course, we know the experience of stigma. Then there are people who, young people who go to learning institutions, and you know what happens in boarding schools when you report, they check, and even parents are not willing to tell the school matrons what this medicine is for. And of course, young people also try to keep away their medicines or throw away because others will see it and find out that they are HIV positive. So that is what we call product stigma. And you know that in Homa Bay, sometimes back, the nation was reporting erroneously that people were throwing away medicine. People were not throwing away medicine. People were throwing those bottles and taking this medicine and tying in laces or in paper so that if they go home when it is tied in the lace. Of course, when it is kept like that, the potency goes and then the people start having challenges. So as we move on integration, the reason why it is important to involve recipients of care even in checking the integration guidelines is to safeguard those who feel that if I go here, then I'm exposed. There's no confidentiality, there's no privacy. People may find out, including in the pharmacy where I collect this, people will see the drug that I pick. I think that is the challenge that we've had. But so far, so good. We know this is the direction to go, and it is not lost on us. So I think the teams that are here, and we have the head of NASCOP here, it is not too late. It is time that we worked in a systematic manner. Lastly, and more importantly, as we move on with the integration, there are lessons that we have learned, differentiated service delivery. I don't think somebody who is coming to a facility to pick medicine should go through the OPD, register and pay 200 shillings, and then wait. What are you waiting for? And you are not going for a lab visit. So even in that integration, we have put aside the issues that we've learned about multi-month dispensing, and there are issues that we put about the community area groups. And I listened keenly to the other speakers. I didn't hear any role assigned to recipients of care. And I think they have a significant role to help the Ministry of Health also with off this challenge that we now have, especially now that funding from US government may not be there. Thank you.
All right. Thank you, Nelson. I think you have shared a lot of important insights for us to ponder on when it comes to this integration conversation. I want to pick on a few. I think one of the things that you have mentioned is that integration might not still be clear to our recipients of care. What do we really mean by integration? And that one of the things that was really a positive push factor for recipients of care for integration was that non-communicable diseases would be covered and that services would continue to be as comprehensive as they needed to be. I think I want to move, or rather go back to both Casco and Director of Health for Muranga For Dr. James, I think one of the great considerations, or rather the greatest concerns that we are hearing from Nelson is around issues for quality of services. He has mentioned that some counties are giving memos to healthcare workers. Communication is not being made to our recipients of care. And there is definitely concern about the comprehensiveness of the services that will be offered once services are integrated, and also the quality of services. So, Dr. James, what do you think about this? What can we do to ensure that integration does not compromise the quality of care that we give our recipients of care? Dr. James?
Yes, thank you, Dr. Kapanga. And I think those are very key, important highlights. So straight to the question, the answer. When it comes to quality of care and HLH, probably a caveat, for us, we have not given memos as such. We strategically called in the more experienced teams in HIV and TB service delivery, from the CASCOs to the SASCOs at the sub-county level, to map out all clinicians who have had training on care and management, so that they become team leads to sensitize all other health workers that are giving these services in the facilities at the sub-county level. And that in itself, of course, is very key to ensure that there is transfer of skills and also supervision by the peers to ensure that there is adherence to guidelines, quality of care, and quality of service. When it comes to the people living with HIV and generally the recipients of care, I think that is a very important insight, and I think food for thought. What I can briefly share is that in one of the areas where we have had integration, and especially where we integrated services for the key populations, is that they themselves were involved in the decision making, because by default we were moving one site from one physical location to another, and during that transition period, the recipients of care were fully involved in terms of informing them about that physical change, the change of design, and the change of access to that service. So that is, for us, was a good lesson. They supported it, and it has been a success at that level. The other key area, of course, is at the dispensing areas, the pharmacy. That is a discussion we have also had on the side, because in one of our sub-county hospitals, we fully integrated the pharmacy. But I think the next step would be to address what Nelson has mentioned very ably about confidentiality aspects during dispensing and during client education in terms of the pharmaceuticals. So probably we will go to the next step of probably customizing the dispensing areas to ensure that there can be individualized counseling and dispensing, to ensure that, of course, that will not be for HIV alone. Since we are talking integration, it will be for all other dispensing services, because even if one is diabetic or hypertensive, they still require the same client education approach. And therefore, those are some of the experiences we have had. And of course, we also take lessons from some of these very key insights that we are receiving. Thank you.
Thank you very much, Dr. I think if I hear you correctly, Murang'a County has done a lot when it comes to ensuring that our human resources have the technical expertise to be able to continue offering quality services through mentorship, capacity building, and even supervision by those ones that have been doing that as within the HIV program. And I think the other aspect for quality that I hear you talking about is around our recipients of care. So we are also looking to ensure that our services continue to be sensitive to our recipients of care by including them in the discussions around integration, hearing their insights, and also getting, of course, their feedback with regards to how do we best integrate. And still around recipients of care, you've talked about confidentiality as being one of the best practices that we want to be able to incorporate when it comes to offering integrated services. I want to go back to Casco Eunice. You already also mentioned that you have already integrated or have been implementing this strategy of integration of HIV services for a while. Maybe you can help allay some anxiety with regards to, is there maybe a successful model that you can share with us? And how have all these things that we're talking about been incorporated, especially when we look at quality, issues around confidentiality, ensuring that our intended recipients of care have access to services. So maybe you can share with us some insights of one or two models that you have implemented and how you have ensured that all these aspects of service delivery are put into consideration. Casco Eunice.
Thank you very much, Dr. Kapanga, and thank you very much to my fellow panelists who have actually articulated the aspects of integration, and even hearing from Nelson as regards to the concerns, especially from the community. And just to be able to chime into what also the others have spoken about, yes, Kisumu County, especially for HRH, we were lucky at one point when we had reduction of funding and we had to lay off some cadre of staff. We had 71 healthcare workers who were actually absorbed by the county government. So these have been key individuals who have helped us with mentorship and even in terms of working with the other clinicians as we speak about integration. And just to be able to speak about the pharmacy model, for us, that was really among the first items that we actually took, because that was a very low-lying fruit for us, that all our pharmacies are actually integrated. Well, we only have one a referral hospital, that is JOTRH, that still has a dispensing area within the chronic care clinic. But all the others, we actually have we have an integrated pharmacy. The issues of confidentiality came in, and that was actually addressed by having a private area where the clients are able to get in and be able to receive individualized counseling and medication use counseling, and they actually live with their drugs packed with whatever items they had come to pick their drugs with. So the issues of confidentiality, that was already addressed. So we have the OPD model where we actually have an integrated outpatient, and this has really been enhanced, especially with the integrated EMR, where we have One Kenya EMR, the facility-wide. So the clinical rooms, several clinical rooms within our health facility. So we may have staff who are actually supported by PEFA, but in this particular facility where integration in outpatient takes place, all the clinicians are actually under the facility in charge. They are assigned duties appropriately. So when a client comes in, depending on what condition or issues, the clinician is able to open the appropriate module. So if it is a client for PrEP, they are able to get into the PrEP module. If it's a client for CCC, they're able to get to the CCC module. If it's an OPD client, so it's like first come, first served in the facility. So you come in and you're actually able to be seen when you get into the room. And the clinician is actually able to address your concern as a client who was presented to them regardless. So we do not have demarcation that for HIV, you go there, it's one outpatient. And just to be able to mention that the aspect of engaging the recipients of care, this was actually addressed with the clients themselves, that at the point that the facilities were taking, especially for the facilities that took integration before this stop work order. The ones who took it up before this stop work order, the recipients of care were actually engaged, and they were told this is what is going to happen in our facility. When you come in, this is the way things will actually be able to go. And we have one facility that things have really moved smoothly for over a year. I think they've actually been able to do that. As regards to the circular that was sent, that was an emergency. Remember, we were in an emergency situation, and we are faced with a scenario where the healthcare workers who are working, especially for the facilities that had not taken up integration, because remember, it's a process, it's a journey. We had begun it and we had made steps in some facilities, but some facilities were still lagging behind. So that was the essence of the circular, to address the emergency situation, that at the end of the day, our healthcare workers who are actually in these facilities needed to know that they need to provide these services as they see the outpatient. Good enough, our 71 healthcare workers who actually absorbed, we tried to ensure that every facility had a staff who is actually well trained to be able to provide these services. Where there wasn't, we actually worked through the SCASCOs who are actually going to provide mentorship to the facility staff to be able to embrace this particular element of integration. For RAMCA, I think that would actually be also, in terms of for PMTCT, that was done way beyond, and I believe most of the counties have actually been able to integrate PMTCT within our maternal child clinics. We also have integrated laboratory, and we are lucky that also through support of PEFA, we have our molecular lab, which is hosted within one of our county hospitals, and this is actually serving us when it comes to the issues of molecular testing. So integration of the lab also within the other facilities, that was actually done earlier. So it is one lab that is actually able to handle all aspects of laboratory testing that may actually be required. What we are actually working on now, especially, is the clinical integration. And that's where we have this outpatient model. We are lucky that even some of the level 4, other than doing it in level 2 and level 3, we also have some of our level 4s who have also embraced, and they have seen the need, and it is applicable and feasible to them that they would actually be able to have one outpatient, and this is really enhanced with the facility-wide EMR that takes place. Bits of challenges, especially as regards to capacity, and that's why we have said that we have embraced ongoing mentorship CMEs that the SCASCOs are actively engaged with to just ensure that all our providers have the necessary capacity to be able to provide. Differentiated care model really comes in to address the issues of the workload. Yes, we truly appreciate that the numbers may be high. So we are adapting and implementing efficient triage system just to prioritize the high need cases. And we know that for the clients who are actually stable, when they come for their drug pickup every 3 months, they go direct to pharmacy. We also have the community ART groups, which are peer-led, and they can actually be able to pick their drugs and be able to have them pick them within the community areas. We are also going to be implementing the community pharmacy model, which we are about. We have already trained 10 pharmacies, identified 10 pharmacies, that for clients who will actually be willing to have this convenience, they'll be able to pay a small fee to the pharmacy who will actually be picking their drugs from designated facilities. And these clients will only be going to those particular pharmacies to be able to collect their drugs, especially the drug pickup. But the clinical visits, they'll still be able to come. So we are trying to triage and be able to have appropriate bookings, that we don't end up with so many bookings in a particular day. So for the 6 months clinical visit, so that isn't up the outpatient clinics that are integrated. I think those are the insights that I actually have for this. Thank you, and over to you, Dr. Kapanga.
Thank you very much, Eunice. You addressed a question that I wanted to ask towards the end around differentiated service delivery. And I think it is encouraging to see that we are still implementing we continue to implement the strategies that have worked for us as a program, because we are not saying that integration is coming to replace what we have already done. We are saying that integration is just but one of the strategies that we feel as a country is going to help us to work towards being able to offer, or rather being able to sustain HIV service delivery. So one of the, I think it was Dr. James or Dr. Lely from Kilifi, who talked about leveraging on FIF within our facilities when it comes to sustainable funding of the HIV program. I would like to pick up from that conversation and direct a question to the head of NASCOP, Dr. Mulwa. What are some of the financing implications of integrating HIV services, and how do we envision that both the government working together with donors will be able to ensure sustainable funding? Dr. Mulwa?
Thank you very much, Dr. I think I have listened into the reflections from Nelson, team from Kisumu, Kilifi, and Muranga. And the question that you raise about integration and financing is very critical, in the sense that we have been running not just HIV, but several vertical programs: HIV, TB, malaria, immunization program, RAMCA, as vertical programs. And sometimes even beyond the programs, even the HIV program, sometimes you find there are silos within the program. For example, when you're talking about HTS, HIV testing and services, may not be speaking to HIV care and treatment services, may not be speaking to pediatric HIV, may not be responding to the adult HIV programming. And one of the things that we need to look at is integration brings in is the issue of synergies and building efficiencies for limited resources. This is actually especially so and we have had this conversation as a theoretical conversation, that donor funds have been going down, and this conversation has been on maybe for the last 15 or so years. But now, this year, we find ourselves in a situation where within a matter of days, the resources almost near zero from one of our major funders, who is the US government. That therefore means we must look at integration as a source of creating efficiencies, and therefore optimizing the little resources that we have in terms of making the most out of resources. I think, and I have said this in other fora, that like, for example, when you're thinking about the best way to look at integration is even when we are doing a programmatic implementation. I think I have been fortunate enough to serve at the 1, clinical space, 2, in the district management, 3, in the county management, 4, in the national management of services as a director, and recently, of course, in the commodity space, and now in one of the programs. So I have had multiple views of what all this landscape looks at from an integration perspective, and that therefore means we have to, as a country and as a program, work together to develop. I will not call a prototype, because, of course, the HIV pandemic, particularly in this country, has geographical and regional differences, and that therefore means the approach that Kisumu undertakes will not necessarily work for Kilifi or Muranga, and that therefore means we need to come up with a blueprint as a program, or as a Ministry of Health, to guide the counties on how to approach. Of course, learning from peers and experiences from counties has already been said here, and also learning from our peers across the borders. This, therefore, and the ministry has led working with the National Disease Endemic Control Council, has been working on this integration agenda. I think at my last stint in the ministry, I left that we are working on a document which I gladly was completed and launched in December this year. So I know in the donor space, especially in the PEFA funded in implementing partners, there have been efforts in some 11 counties for government to government funding, where counties have been onboarded as recipients of global of PEFA grants, and the implementing partners in those counties have been working to supervise. This is actually one of the ways of, and one of the major challenges that we have even with the USG funding is because most of the funding that happens within the HIV space is extra budgetary, funding, and therefore we do not have proper visibility of what withdrawal of these funds means, and that therefore means when the G2G approach that has been happening enables counties and to be able to understand, to have a feeling of the budgetary requirements, and being able to apply resources where in case or if, and it's actually not if, when our partners eventually will win us off donor funding, we should be able to have a proper understanding of the mechanics of running programs. That said, I think we as a government have also an opportunity to look at the landscape of the health financing sector, take advantage of, for example, the social health insurance and the universal health coverage agenda to ensure that not just HIV services, but vertical programs that have we included, or how can we ensure that the services that are received by the citizens who are members of the social health authority, be it outpatient services, be it laboratory services, be it inpatient services that are offered to these clients, whether HIV positive or not, are covered. And that therefore means we would avail extra resources to the health system that will be able to guarantee continuity of services. And that therefore means integration may be of benefit to the system and the clients using the new funding model. Thank you, Dr.
Thank you very much, Dr. Muno, for sharing with us those very important insights from the government side with regard to what we expect coming in terms of financing, and also in terms of policy and regulatory changes for HIV services. I think you have touched on some of the documentation and policy that we expect to be coming from the Ministry of Health and NASCOP as a program that will support the integration agenda, and hopefully allay some of the concerns and fears that were raised earlier by Nelson, who talked about the fact that communication is going out through memos and not through guidelines. So I think we look forward to having those documents so that the different stakeholders and constituents can use it also as a reference point. You've also mentioned the sustainability operational plan that was launched December 1 last year. And I think that is also a good document that we can make reference to, even as we are working around integration of services. To give us some time, maybe to respond to questions, if any will come up from the participants, I would like to just ask one last question to Nelson. So we are all here because we have recipients of care to offer services to. And we want to be able to ensure that we maintain the momentum that we have had as a program. So for those of us that are not within the HIV space, by UNAIDS standards, we have surpassed the targets of identifying more than 95% of our people living with HIV, estimated to be living with HIV. We are at 98%. We have also been able to put almost all of them on treatment, that is on antiretroviral therapy. And we are at 94% when it comes to viral suppression for our recipients of care who are on antiretroviral therapy. So we are doing quite well as a program. So to you, Nelson, my question would be, how or what can we do, or how do we ensure as a program, as healthcare workers, as government, that we meaningfully continue to engage our communities, the communities that we serve, that is both communities of people living with HIV and communities of people that are at risk of getting HIV and STIs. What can we do better, or how can we strengthen our engagement with the communities, even as we go ahead with this integration agenda? Nelson?
Thank you, Dr. for having me back. As usual, we'll go to your question after I raise a few points very quickly, because I know we are constrained of time. I just wanted to have a reflection and say that Kenyan HIV epidemic is mature. We have matured, and in the science and the treatment and in everything, there is no emergency. Even if Trump comes back in 90 days and say no more support, there should be no emergency. So a memo to address emergency should not surface. I think we should follow the science and agree that yes, we have this HIV, we want to own it, we want to move forward. Let us work on proper guidelines with the involvement of recipients of care, and then step by step we will follow that. Secondly, let us define integration, and that definition, let it include recipients of care, what they understand by it and what they foresee. Because sometimes they go for meetings, they support integration, but when the implementation starts, they realize that what the Ministry of Health understood is different from what they understood. Because what we have seen happen in the last 2 weeks is just a matter of delivering services, which actually is good because somebody had to do that. But in the opinion of what we anticipated, that is not integration, because it is just a matter of getting you have HIV, go there, get your medicine, go home. I think safeguarding medicine is important, but people may have other issues. The Kisumu model of OPD, which is also good to help us for the time being, it also does away with health talks. It does away with the psychosocial support. There are things that you can not raise when you have recipients of care of HIV, also having people who have malaria, other conditions, and so on and so forth. And the best thing is to take some of these things to support groups at the community level, where the healthcare worker can be visiting occasionally, and then giving discussions on what it is they want to hear. I just wanted also to touch on what you gave us in the definition with integration, digitizing health. And of course, in Kenya, we have always been ahead of other countries, and we talk about EMR. And of course, in 2022, NASCOP asked us to go what we call verification or validation of PLHV on treatment. And we accepted. We said we will go with our ID so that people are verified and counted. Of course, up to today, we don't know the results. We were told there are 7 nasal counties, there was no partner, and so on and so forth. But we are realizing with this integration, and this is something that we have picked from Kilifi, that actually EMR probably was not even a NASCOP or was not even a Kenyan in other counties. And we are facing healthcare workers who are asking recipients of care if they know the medicine they have been. And we are going back to paper, the files. And I think that's really very unfortunate, because we thought that the data, going by Data Protection Act, was Kenyan data and was being used by Kenyans, and those laptops or desktops were being owned by Kenyans. But anyway, going forward, we are in this together. We know the Ministry of Health works to sustain and preserve the health and well-being of communities, including those who have HIV. In other forums, we have raised questions why then HIV is not under Social Health Authority, but that is not for this meeting. To strengthen engagement with recipients of care, we have networks like NEFAC at the national level, and we have networks at county level, support groups that are available. It is not easy to be in 47 counties. That's why, for me, I engage in NASCOP or Ministry of Health or NSDC and my colleagues at the national level. But in each of these counties, especially the ones that are represented here, we have vibrant recipients of care in support groups and networks that if you wanted to link up with them, you will get them. And actually, it is from there that even I've gotten a comment from Muranga 2 days ago on the integration. And that's why we are appreciating, because what they did was, in terms of recalling the experience healthcare providers, has brought in people who have history with managing HIV and handling recipients of care who come in for HIV. And when you bring in new people, and maybe just to end it here, I want you to know that even within the Ministry of Health, county or national, when you are in the HIV space, people think you have a lot of money. Whether you're a person living in the HIV or a healthcare worker in the HIV, people think you have a lot of money. In fact, there are some certain people who work in the HIV, including at the county level. If they are transferred to other departments, they would rather resign. Now, when you are calling other workers to come to help you with HIV work, they think that you are calling them because the money has gone. And this is when you are calling them. When you had money, you did not go for them. And that's why the counties that started long time ago, like Muranga, will succeed very well. Back to your question, whether it is a young people, whether it is men, whether it is women living with HIV, they have networks and leadership of people who can engage and inform services and be part of decision making, with the understanding that the work they do belong to the Ministry of Health. Theirs is to give an input to make the services better for their peers and for themselves. Thank you very much.
Thank you very much, Nelson, for those remarks. I would say parting short remarks. So at both county and national level, we should be able to engage the networks of our recipients of care so that we ensure that even as we are navigating this integration conversation, that we hear from them. We hear from the people that we are here to serve. So thank you very much, Nelson. Nelson of UON, I don't know if you're there. Maybe you can help us navigate the Q&A. I think I have seen quite a number of questions there. We have 10 minutes to the end of the session. So please guide us on how we are going to navigate the Q&A session. Nelson?
Thank you, Tim, for such a wonderful discussion. I think we can see all the feedback represented by all of these questions we can see on our Q&A section. Moving forward, I think I can encourage all of our panelists, if you see a question that you can answer on behalf of the other panelists before we come to questions that we can tackle in this discussion, please go ahead. In the meantime, Dr. Kapanga, you can go through the questions and pick the ones that you feel have more weight, and we can address them during this session before time ends. Thank you.
All right, so let me pick randomly. There's a question around, with the withdrawal of USAID, how are the ARV recipients expected to navigate? So I don't know, Dr. Mulwa, if you're here, if you don't mind, maybe you can talk about the commodities, just so that our attendees are well appraised in terms of commodities, despite what has been happening with USAID. Dr. Mulwa?
Thank you very much. I think one thing I can say is we continue to monitor the commodity situation on the country on a day-to-day basis for purposes of assurance of our healthcare workers who are joining in and communities who are in this webinar. We have sufficient stocks, especially of first-line products in the country to last us well to the end of the year and up to the next budgeting cycle. The Global Fund and the MOH and National Treasury pipelines are still providing sufficient stocks. With the current waiver that we have received on the stop orders, we expect to receive further commodities, especially with the first line. I would say that the pipeline that would easily be affected by the stop orders in the immediate would be the pipeline for EID and viral load testing, which we are working with KEMSA and the ministry to ensure that we get a mechanism of distributing the product because the products are in country. And therefore, if the challenge would be getting facilitation to distribute, but for purposes of the community and everyone, in terms of commodity supply, we are okay for both testing services, care and treatment, and both pediatric and adult. That's what I would say. We have we look at the commodity situation on a month-to-month basis, and from where I sit, we are good. And I have an advantage of having worked in KEMSA to know that the stage of procurement that are ongoing for the first line commodities and other commodities. So for us as a country, we don't foresee any immediate challenge, and that therefore should reassure our clients that they will have their commodities as and when they require them.
Thank you. Thank you very much, Dr. Mulo, for that reassurance for our participants who have joined in today. I see there's so many questions. I'm having trouble picking out which one to address. So maybe we can pick one more that is also a system level issue. There are some questions around HRH. So there's a comment that the HRH, especially the lay cadres, are important, play a big role on issues concerning stigma reduction, and there is a need for us to think about maintaining them within the system, either as support staff or casual workers, instead of sending them home. So I think maybe I will request our Director for Health for Murang'a County to just say something around human resources, at least from the perspective of Murang'a County. We know that human resources for health are managed at county level. So while you make your statements, the statements might not be representative of all the 47 counties, but it would be good to maybe just reiterate what is happening around HRH, especially the lay cadres, care educators, mentor mothers, and such. Dr. James?
Yes, thank you for that. Regarding the lay cadres, we have actually engaged at high level at the executive to see how to actually maintain or onboard them into the mainstream workforce through the two mechanisms that you have alluded to. So the County Public Service Board is fully seized of that matter. On the other health workers, we were lucky that some had actually transitioned through movement from the programs into being onboarded into the public service. And those are the ones we are mapping to ensure there is skills transfer and capacity building. And I think the other key approach will be, of course, capacity building for the other mainstream staff to render these services. And one of our key entry points would be the multidisciplinary teams, where we are able now to bring on board even the senior members, the physicians, especially for management of the more difficult cases or the complicated cases, both in HIV and TB. So I think we will have to have a team approach and multi-pronged approach in this HLH issue to see actually what works best in each of the circumstances. But I think this is a good session for all of us to pick these points from different counties and even at the national level in terms of the HLH component. But of course, communicating with the key stakeholders that we alluded to earlier to create that buy-in, to avail the budgets by the assembly and the county public service boards is extremely critical. Thank you.
Thank you very much, Daktari. So just to add on, and I'll address Dr. Mulwa for this. So there has been the challenge of some of the human resources for health within the HIV program that are not aligned to the schemes of service. For example, the adherence counselors and the HTS providers. So I see one of the questions here is what plans do we have for those cadres? And then just maybe a last question to you, Daktari, so that you address them together. I see we are running out of time. Somebody is asking now we are talking about CMEs and mentorships, and there is no money to facilitate this. How are we going to go around it? So is there any plan from NASCOP to ensure that we uphold capacity building, even in the face of reducing donor funding and maybe reduced capacity to be able to hold trainings or hotel-based trainings? So maybe just those two questions. And then I would like Dr. Mulwa to answer the questions and then give some wrapping up remarks. So we are going to download these questions and address them and share via email. And in addition to that, this is a 5-part conversation or series. So we are going to have the other sessions talking about other aspects of integration. And hopefully by the time we are done with the 5-part series, we should be able to have addressed all the questions that have been put forth from this conversation today. So I'm handing it over to you, Dr. Mulwa, to respond to those two questions and help us wrap up the session. Karibu, Daktari.
Thank you. Thank you. I think I will start by addressing the issue of non-core cadres, non-recognized cadres that you rightly mentioned. And this would be my response, that we are in a situation where the healthcare landscape is supposedly supposed to have very, very major changes. And one of the major changes is the enactment of the health laws that was done in 2023, which created now the Social Health Insurance Fund, the Primary Healthcare Fund, the user fees, and the digital health. How do we address some of this? One, the Primary Healthcare Fund, as is, recognizes service delivery in level 1, 2, and 3, and provides for publicly financed primary healthcare services. Some of these cadres can easily be adopted in the PCN networks and through the community health structures that have been are being established or should be established. The challenge that I think we continue to see is because we shifted from NHIF to SHA without first establishing the foundational primary healthcare fund. And that sometimes obscures our thinking on how the health landscape should be. So I think from where I sit is with the primary healthcare fund, we can be able to engage non-clinical community-facing cadres in the health system. And to me, I think is the conversation. And with my experience, because when I was working in Makueni, and I think must have been LVCT that was exiting, and we had a way of introducing what we called community health cadres at the time, which were non-existent in 2013. And that therefore means it is about prioritization. It's about what the policymakers understand as the value of these cadres. Then the other question that had come through, Dr. I may have answered one question and forgot about the other one, is the issue of, what was the second issue? Dr. Kapanga, the non-cadres, the second question was on?
So, Dr. I think you might have answered both questions, if I'm not mistaken. I'm just trying to scroll the chat box to get the question.
Okay, maybe we could wrap it up and say, one, we are in a fluid and quickly changing dynamic in terms of the health system in the country. It is upon all of us in the spaces that we occupy to ensure that we tailor our health system to serve the needs, one, of our people, and to best serve the interests of even the providers. And that therefore means the government shall and should continue. And Dr. I want to agree with you that what was the issue of trainings? The question was you leverage on technology. Now that one, we recognize as a government, part of the things that of the proposal that we have put through for financing is to scale up capacity building of healthcare workers on not just HIV, but to equip our healthcare workers with the capacity that is required for integration to happen. Because as we experience drop in donor funds, then it will mean to be innovative. We will do on-job trainings. We will facilitate online webinars, online trainings and webinars, and incentivize the healthcare workers to join these trainings by offering CPD points and other incentives that we can be done. With the Digital Health Authority, we should be able to have platforms and train it. We should also have online materials or tools that can be available for healthcare workers to study and also get certification when they go through certain training. So these are available even in the Ministry of Health, and we want to use such platform to continue training. But we will avail resources to at least have or champions or TOTs for every county to ensure that they help build the capacity of the others in the county. Thank you very much and have a good evening. I want to thank the 1.4 thousand, which is 1,400 of us who have joined this call, this webinar, and all the panelists for your insightful contribution. And we look forward to working together to not just make the health delivery system in the HIV space work, but the entire health system work for the people of this republic. Asante.
Asante sana. Good night and have a good remaining of the week.